I'm Jeremy Kortmansky. I'm a medical oncologist on the GI oncology team. I'll be the host for this third of our four CME events in GI oncology. Today, we are going to have talks on supporting our patients. I am joined by Laura Baum, who is a medical oncologist in GI oncology, and Mongiu, who is a colorectal surgeon. And then Liz Prsic will be joining us shortly, I hope, who has joint appointments in both medical oncology and palliative care. Each of us will talk for about 12 to 15 minutes or so. And then we will leave time, preferably at the end, for questions. So I will be giving the first talk on the impact of lifestyle on colon cancer incidence and recurrence, followed by Dr. Baum, who will be talking about cancer-related distress and traumatic stress. Then Dr. Prsic with what's old and new in support of oncology. And then batting cleanup, Dr. Mongiu on managing low anterior resection syndrome. So I'm going to take a moment to share my screen. I'll be following for questions in the chat as well, so feel free to put them there as we go. Okay, so there are many causes of cancer that are endogenous, such as genetic, metabolic, and hormonal, exogenous, diet, physical activity, tobacco and alcohol intake, and then environmental, radiation, stress, infection, and toxins. And it's some or all of these factors that lead to our risks for cancer. But what we can modify are really those exogenous factors, such as diet, physical activity, smoking, and alcohol. And there's the most evidence that dietary habits and physical activity can impact incidence and outcomes. Most of this research has been focused on breast cancer and colorectal cancer. And today I'll be focusing on what we know from colorectal cancer. But as an intro, about 1 in 5 cancer cases are associated with excess body weight, poor nutrition, physical inactivity, or excess alcohol consumption. And being overweight or obese raises a person's risk of getting 13 different cancer types, of which 6 of them are in the GI system, including esophagus, liver, gallbladder, stomach, pancreas, and colorectal cancers. Both diet and physical activity influence obesity, and that excess weight is attributed to an increased risk of cancer-related deaths in 14% of men and 20% of women. And these factors affect both cancer incidence, treatment outcomes, quality of life, and survivorship. But there's still a real limit on the number of randomized controlled trials that we have. Obesity is a chronic inflammatory state, and it leads to elevated levels of pro-inflammatory cytokines and changes in adipokine secretion, leads to oversecretion of insulin and increased release of IGF-1. Insulin and IGF-1 suppress apoptosis, promote cellular proliferation, angiogenesis, and that pro-inflammatory state favors tumorigenesis, and chronically low levels of anti-inflammatory products promote angiogenesis. In a cartoon here, the insulin receptor has an impact on a number of different pathways that are related to cell proliferation, apoptosis, and other non-metabolic activities. Most of what I'll talk about tonight reflect nested cohort studies because there is a limit on the number of randomized trials. The advantage of a nested cohort study is that the baseline characteristics of the study population, including disease stage and treatment history, are homogeneous. The treatment regimens are controlled after patients are randomized, and patients receive frequent comprehensive evaluations, including assessment for disease recurrence or progression. The disadvantages are that they are observational and not randomized, and many of these studies looked at a clinical trial population that may not be reflective of the general population, as they largely included a white non-Hispanic population. CALGB 89803 was an early adjuvant trial in stage 3 colon cancer, comparing weekly 5-FU to weekly irinotecan and 5-FU. This study was a negative study from the chemotherapy standpoint, but there was, as part of this study, patients were asked to complete a questionnaire completing diet and lifestyle habits, both midway through their adjuvant therapy and then 6 months after completion of their adjuvant therapy. And this allowed the investigators to obtain a lot of information about diet and physical activity. Patients that had either recurrence or death within 90 days following completion of their first survey were omitted from the assessment so that there wasn't bias based on a declining performance status. One of the first things they looked at was the dietary glycemic load and its impact on recurrence and survival. They measured glycemic load based on reporting of various foods in the diet. And what this showed is that across multiple subgroups, based on age, sex, performance status, number of lymph nodes, the treatment arm that they got, activity, that glycemic index, patients that had a low glycemic index had the best survival, and patients that had a high glycemic index had the worst disease-free survival. Interestingly, this was the case in all of these subgroups, except in patients that had a low body mass index to begin with. So a BMI of less than 25 kilograms per meter squared is a low BMI, and that was not and that glycemic load did not impact survival in that patient population. In another prospective cohort from the Nurses' Health Study, the Alternative Healthy Eating Index was a score based on high consumption of healthy foods like vegetables and whole fruit, nuts, et cetera, and low consumption of sugar-sweetened beverages, red processed meat, high salt, and alcohol consumption, and again showed low overall mortality if you had a higher score, and also a borderline significant improvement in colorectal cancer-specific mortality with a higher score. What's interesting is that a lot of that benefit was driven primarily by the sugar-sweetened beverages and low alcohol in the diet. Nut consumption is another way to think about a healthy diet. A high nut intake is associated with a reduced risk of type 2 diabetes, metabolic syndrome, and insulin resistance. And individuals who consumed greater than or equal to 2 servings of nuts per week had an improvement in disease-free survival with a hazard ratio of 0.58 and an improvement in overall survival with a hazard ratio of 0.43. This benefit is limited to tree nuts like walnuts and almonds, and not peanuts or peanut butter. And although these different subgroups were not powered enough to be statistically significant, you can see that there is clearly a trend in favor of the nut intake across a number of different subgroups, including the number of positive nodes, body mass index, physical activity, and even some molecular markers. My favorite, coffee intake. was also associated with an improvement in recurrence and mortality in patients that had greater than or equal to 4 cups per day of coffee compared to non-drinkers. Non-herbal tea and decaffeinated coffee had no impact. I will add the disclaimer that there have been other studies that have shown more equivocal results related to coffee intake, and also in tea products. So the take home from this is not that we should be requiring our patients to drink 4 cups of coffee per day, but that if they like coffee, there's no reason they should stop drinking it, which often comes up in our conversations. Switching to physical activity, this also reduces the risk of colorectal cancer, and it does so in a number of different ways, including attenuating the hormone response to stress, increasing the IL-6 production, which leads to a cascade of anti-inflammatory cytokines, which in turn reduce the levels of insulin and IGF-1, decreases central deposition of adipose tissue, which is a higher risk. So visceral adipose tissue is a higher risk than subcutaneous, and then alters prostaglandin synthesis, bile acid secretion, or gut flora, as well as improves our immune surveillance. There have been a number of prospective observational studies that have looked at the effect of post-diagnosis physical activity on survival. And I'll comment on a couple of those studies. The first also goes back to CALGB 89803, where they looked at the metabolic equivalent task, a MET hour per week of physical activity, and showed that compared to less than 3 MET hours, those who had 18 to 26.9 had an improvement in hazard ratio, or had improvements in disease-free survival, and those who were super active at 27 plus had a hazard ratio of 0.55. Now, I know everybody's asking, what is a MET hour? And so this is a table that helps kind of clarify what different exercises are equivalent. And so if you walk for 1 hour at a normal pace, then that is equivalent to 3 MET hours of activity. So to achieve 27 MET hours a week just by walking, you would need to walk 9 hours during the week. More vigorous activities are associated with higher MET hours. And then based on what a patient is doing, the different activities are then added up to give you your number. But as we could see in this Kaplan-Meier curve, patients who had more than 18 MET hours per week had an improved disease-free survival compared to lower volumes. And so this is the impact on not just recurrence, but also mortality. And again, the more active you are, the better your survival. In another study from 80702, so this was a clinical trial that looked at 3 versus 6 months of FOLFOX with or without celecoxib. For this study, the IDEA collaboration has been well reported elsewhere. The celecoxib arm was negative, but patients also received surveys here. And based on looking at disease-free survival and overall survival, the more active you were, the better your disease-free survival and overall survival was. And there does seem to be some linear relationship, so it is not limited just to achieving greater than 18. Any exercise as you go up shows some benefit. What's also interesting is that the type of exercise that people do is not so important because we saw the same benefits whether it was vigorous activity, light intensity activity, or muscle strengthening activity. It's really achieving a certain level of activity across the week that makes the difference. And again, we see these benefits across multiple subsets of patients, independent of sex, of BMI, of their risk group, meaning their lymph node status at the time of randomization, whether or not they had gotten the celecoxib, and whether or not they had received 3 months or 6 months of treatment. This last study looked at physical activity in patients with metastatic disease. So the first two were patients that were getting adjuvant therapy. This was looking at patients with metastatic disease, and again showed what it showed was that there was no change in overall survival based on activity, but there was an improvement in the number of grade 3 treatment-related adverse events. And so while patients were not necessarily living longer with the physical activity, their experience of their treatments were better. And this is seen in this Kaplan-Meier curve where the red line reflects those patients who are achieving greater than 9 met hours per week. So the benefits of physical activity are that it improves the tolerance of chemotherapy, which can help improve dose intensity of our treatments, and it can improve disease-free and overall survival, independent of other risk factors that can influence one's outcome. So based on all of this, the American Cancer Society has made the following recommendations for patients to maintain a healthy body weight, which means a BMI less than or equal to 25 kilograms per meter squared. Sorry about that. Adopt a physically active lifestyle. So 1,200 minutes per week. So 360 minutes per week of walking or 150 minutes per week of vigorous intensity or some combination. Consume a healthy diet with emphasis on plant foods, limit red meat and processed meat, and limit alcohol consumption. This was just a quick reminder of what those MET hours are, and I'm happy to share this with anybody who asks. The take-home messages are that diet and exercise are modifiable lifestyle factors that can influence our outcomes. There is a plausible rationale at a molecular level and clinical corroboration in prospective cohort studies. However, prospective randomized trials are needed that are biomarker-driven and that are inclusive of underrepresented populations. I also want to take a moment to put a plug in for a program that we are piloting through the Teaching Kitchen, the Irving and Alice Brown Teaching Kitchen, and the GI in the Digestive Disease Suite, looking at healthy habits for cooking and education. And we've already had 2 programs for patients with colon cancer to learn some diet modifications for healthier eating, practice preparing and cooking food, and then other tips. So for more information on that, also feel free to reach out. Thank you for your time. Again, if there are any questions that folks have, feel free to put them in the chat. And with that, I will pass the baton to Dr. Baum, who will talk about cancer-related distress and traumatic stress.
I was sharing screen, but I think I just unshared it. Let me try again. Okay, so do you see my the appropriate screen? Okay. So thank you for having me today to discuss cancer-related distress and to focus on cancer-related post-traumatic stress symptoms. So these are our learning objectives. We will start with an overview of distress and cancer with a focus on screening and a brief understanding of physiology, transition specifically to the problem of cancer-related post-traumatic stress symptoms, briefly discuss management of this issue, and finally, end by tying this into together into whole person care. So cancer is the second most common cause of death in the US, and GI cancers account for 1/4 of cancer cases and 1/3 of cancer deaths globally. So we see significant morbidity and mortality, and also a growing population of long-term survivors. Both patients with curative and metastatic disease are at risk for psychosocial distress, and psychological health should be considered in all patients with cancer. So the NCCN defines distress as a multifactorial, unpleasant experience of a psychological, social, spiritual, and/or physical nature that may interfere with the ability to cope effectively with cancer, its physical symptoms, and its treatment. And we see that with the diagnosis of cancer, patients are at risk for the relapse of pre-existing mental health disorders, particularly post-traumatic stress disorder and particularly substance use disorders, but they also can have relapse or re-trigger of pre-existing depression or anxiety. And then what we'll focus on here as well, cancer itself may initiate an acute stress reaction, triggering the relapse of the previously mentioned disorders or triggering new onset cancer-related post-traumatic stress symptoms. So distress screening is widely recommended in guidelines as standard of care, including by ASCO, NCCN, the American College of Surgeons Commission on Cancer, and the National Academy of Science, Engineering, and Medicine. Yet there are significant challenges, and existing guidelines are not detailed or consistent. For example, the Commission on Cancer accreditation standards for patient-centered care do not state when, how, or how often to screen or respond to patients' psychosocial needs. And distress management protocols vary widely in screening characteristics, including instrumentation, periodicity, and procedures for responding to positive screens. So here at Yale, we use the NCCN distress thermometer. And how does that screening tool impact what we do afterwards to assess, triage, intervene, or monitor is extremely heterogeneous between providers. You can see here the NCCN distress thermometer that patients are given on their initial visit with oncology at Yale. To your left is the general thermometer or their general distress. Anything over about a 3 or a 4 is considered to be clinically significant. To the right is a comprehensive list of symptoms: practical, family, emotional, spiritual, and physical. So when might distress or positive symptoms on the distress thermometer be concerning for an acute stress reaction or for cancer-related post-traumatic stress symptoms? I highlighted some obvious symptoms identified as emotional problems, difficulty sleeping or concentrating, or unhealthy substance use that could lead us to believe that a patient is experiencing an acute stress reaction to cancer or experiencing cancer-related post-traumatic stress symptoms. But these symptoms in blue, trouble making decisions or functioning at work or school, social or relationship problems with partners or children, a preoccupation with appearance, physical symptoms, particularly GI symptoms or breathing symptoms, and pain and sexual symptoms could also be a sign of an acute stress reaction. So what is an acute stress reaction physiologically? In response to ongoing real external threats, the amygdala, the emotional center of the brain, may work overtime, and the prefrontal cortex, which organizes our thoughts, analyzes problems, and initiates action plans, can be overwhelmed. When this occurs, we can experience real changes in our way of thinking. We can also, as we become activated and undergo stress, we also release stress hormones. So the increased production of stress hormones, which is part of the activation of our fight or flight response, can lead to symptoms of anxiety and distress that we experience mentally and physically. Somatic symptoms such as heart racing, cognitive symptoms such as disorganized thought, affective or mood effects such as persistent sadness, or behavioral symptoms such as obsessive or compulsive behaviors, amongst many, many others, may be a sign of an acute stress reaction. These changes in our physical and cognitive symptoms can further activate our alarm system, creating a vicious cycle that magnifies our sense of loss of control, our inability to organize our thoughts and make decisions, and our sense of helplessness. Not only are we out of control over our cancer, but our own reaction and feelings and ability to think through things also become out of control. So let's move with that in mind into cancer-related post-traumatic stress symptoms specifically. You won't be surprised, hopefully, at this point to see that general distress is strongly associated with what we'll define shortly, which are cancer-related post-traumatic stress symptoms. I'm going to try to speak a little slower so people can follow. So here on the left, you see a figure of patient scores on the NCCN distress thermometer, which we remember was scored 0 to 10 for how much general distress the patient is in. And on the y-axis, you see an assessment for post-traumatic stress symptoms. You see on the left the patient, and on the right the caregiver. This is data from a dyad study that I did. And you can see that as the distress thermometer scores go up, so do the post-traumatic stress symptoms. So what are post-traumatic stress symptoms? Let's take a minute to define them. I've been mixing terminology to this point in the talk, using the expression post-traumatic stress symptoms, using the terminology acute stress reaction or acute traumatic stress. I've been using these terms more or less interchangeably to highlight the symptoms rather than the formal diagnostic criteria. But what are considered the post-traumatic stress symptoms? Specifically, by DSM-5, these are the symptoms that eventually could be categorized as PTSD. So these are re-experiencing of the traumatic event, avoidance, arousal, formerly hyperarousal, and negative alterations in cognitions and mood. The post-traumatic stress symptoms come from PTSD diagnostic criteria, which include the symptoms, as mentioned, intrusions, avoidance, changes in cognitions and mood, and arousal and reactivity, plus other qualifications such as number of symptoms, duration of symptoms, and a qualifying event. The DSM-5 has reclassified, compared to the DSM-4, PTSD from an anxiety disorder to a trauma and stressor-related disorder. So there is controversy about whether cancer is appropriately considered traumatic enough to qualify as a qualifying event, but that is beyond the scope of this discussion. What matters for us is that cancer may trigger post-traumatic stress symptoms, that these may lead to persistent impairing stress, that this persistent impairing stress is accompanied by worse function and lower quality of life, that these symptoms can be so severe that they are consistent with the full spectrum of PTSD, with or without the qualifying event, or they can be more intermittent or subsyndromal. Intermittent or subsyndromal symptoms are also potentially impairing and can also decrease quality of life. So to summarize, the general idea is that as acute and peritraumatic stress symptoms become chronic adaptations, the failure to respond and address the acute stress reaction or the post-traumatic stress symptoms can lead to a persistent dysregulation and a failure of psychological recovery, which impairs patient quality of life and function. I hope everybody's wondering how common this is at this point. And given that I just said that cancer may not even be counted anymore as a qualifying event, I think it's very interesting to note that in earlier studies, PTSD, the full syndrome PTSD, was commonly identified in patients with cancer. The original PTSD cancer PTSD field trials showed a lifetime prevalence of 22%, but there's been extreme intra-study heterogeneity between study heterogeneity. So it's difficult to pin down exactly. Part of that has to do with the timing of the assessments and the qualifications of what counted as formal, as diagnostic criteria. I think it's important to note that post-traumatic stress symptoms don't have to occur at diagnosis. Cancer is not a one-time assault. Symptoms can occur at any time throughout the course of illness and may be worse in patients living with advanced cancer. Patients with ongoing treatment in advanced cancer or high symptom burden have persistent vulnerability to high levels of stress, given ongoing triggers such as continued uncertainty, forced passivity, and intrusive treatments. Just for the audience, patients with GI cancers may be at higher risk of post-traumatic stress symptoms, particularly when they have structural GI changes or fecal incontinence. But a recent study of colorectal cancer survivors and their caregivers, even 2 years out, showed persistent high levels of post-traumatic stress symptoms. And it also may be more common to have impairing symptoms in younger patients. In the study that I referenced earlier, the caregiver patient study, we found that 44% of young adult patients and 52% of their caregivers had clinically significant cancer-related post-traumatic stress symptoms around the time of the new diagnosis. So this is a common, bothersome, potentially disabling problem for patients with cancer. If you don't believe the terminology and you're wondering if there's another way to think about this without using PTSD language, there is also a growing interest in what's called the fear of cancer recurrence or progression, or FCR. FCR is characterized by worry, fear, or concern, with 4 key characteristics that are very similar to cancer-related post-traumatic stress, with the additions of hypervigilance to bodily symptoms. FCR may be a reasonable surrogate for cancer-related post-traumatic stress symptoms, and similarly to post-traumatic stress symptoms, fear of cancer recurrence can increase dysregulation and raise levels of stress. Like post-traumatic stress symptoms, fear of cancer recurrence is experienced as a loss of control and a helplessness while facing persistent danger. It's also treated similarly to PTSS or PTSD, and rates are also very high. In a study of young adults, cancer survivors, FCR was noted in about half of the population. So I hope that gave you an idea of the problem. We'll briefly touch on management before concluding. So traditional treatment options for post-traumatic stress symptoms include CBT, cognitive-based therapy, which would require a psychiatry or psycho-oncology referral, which may be a limited resource. For some patients, it may be worth keeping in mind that they could see social work or even chaplaincy. Chaplaincy may be particularly helpful for patients where their distress is expressed through spiritual distress or expressed particularly through the fear of death and dying. But there are also prevention options to address acute stress response and post-traumatic stress symptoms proactively that I think we can learn to utilize with our patients, at least in a brief fashion. 2 practical strategies are to utilize psychoeducation and to engage the patient's social support. Social support is a key predictor of better outcomes as it decreases the patient's sense of isolation. It also likely mitigates the caregiver post-traumatic stress response. And psychoeducation, I think, can help the patient and their caregiver put words to a common response, improve their cognitive symptoms, and organize their thoughts, identify their thoughts, and communicate their experience. This can help improve coping and communication between the patient and their caregiver and their provider. So this is an example. You don't need to read it in detail, but this is an example of a psychoeducation worksheet for patients experiencing acute traumatic stress. You can see the identified problem, trouble sleeping, the identified symptoms such as racing thoughts at night, strategies for coping, and an explanation of why it works. Here's another example of relaxation techniques that may help a patient to calm their body and organize their thoughts, such as focused breathing, progressive muscle relaxation, and mindfulness. Sleep hygiene is another topic, but also may be helpful. So finally, I wanted to spend 1 minute talking about an initiative we're doing in the GI Oncology Clinic to establish an integrated GI onc and palliative care supportive care clinic on Thursdays. As our first quality improvement initiative in this clinic, we've created a screening tool for patient-reported symptoms, including together physical and emotional symptoms of cancer related to toxicity from treatment, related to symptoms of cancer, and related to cancer-related distress. So this is our patient symptom reporting tool that we're using in our integrated clinic, and it includes a general distress screening at the top, as well as other symptoms, the last of which on there, you can't see, it's probably very little, is fear of cancer recurrence or progression. So in conclusion, distress screening in cancer is heterogeneous, challenging, and important. It's a common problem that patients face, and there are solutions to work on it. Cancer-related post-traumatic stress and fear of cancer recurrence are also common problems with lasting effects on quality of life and function. Psychoeducation and identification of distress are the first steps toward improving symptoms. They're therapeutic themselves in the ability to identify the common response and organize one's thoughts, but they can also lead to other effective psychological treatments. And whole person care includes physical, emotional, and social well-being integrated into our care delivery. So thank you very much.
Thank you, Dr. Baum. Again, if there are questions or comments, please put them into the Q&A and we can address them. Moving to our next talk, Dr. Prsic will discuss what's old and new in supportive oncology.
All right, thank you guys so much. Give me a second here. I'll do my screen share. All right, can everybody see that? Thank you. All right, so I'm going to cover what's old and what's new in supportive oncology, pearls, and GI malignancies. I'm Elizabeth Prsic. I'm firm chief for MedOnc, and I'm also director of adult and patient palliative care. So I'm double boarded and really focused on the inpatient management of patients, and also cover on GI consults. As you can imagine, there's a lot of both on the inpatient service. So today I'm going to go through pain management and common opioid prescribing challenges, olanzapine for cancer cachexia, prophylactic radiation for high-risk bone metastases, brief update on marijuana use among patients with cancer, and then finally close with diclofenac for hand-foot syndrome. Now, I know we have 10 minutes, so this is gonna be rapid fire. I hope you're paying attention. We'll send the slides around. Don't worry about taking notes, and feel free to interrupt with questions. So I'll just keep moving. I am the one of the associate editors for New England Journal of Medicine Watch for Hem-Onc palliative care, really with a focus on supportive oncology. That's the one disclosure I have. Wish I had more. Cancer pain, why is it so important? So we know it's prevalent. We know our patients experience a significant burden of cancer, especially among patients with GI malignancies. Up to 90% of patients with advanced disease do experience cancer-associated pain, the majority of which is related to direct neoplastic involvement. Of course, issues related to comorbidities, treatment effects, and other sequelae of treatment and surgical complications, which we'll go over as well, come into play. So given this, despite all of the burden of symptoms, the majority of patients can be treated and managed for their pain if treated according to guidelines. So cancer pain, even if severe, even if prolonged, is treatable. And why do we care so much about cancer-associated pain? Well, poor pain control can certainly contribute to depression, anxiety, delirium. It can lead to decreased socialization, issues of sleep, issues of appetite, gait instability, increased risk of falls, which can affect performance status and all the rest of it. This makes it much more difficult to treat our patients and also detracts significantly from their quality of life, as well as the quality of life and role of their supporting caregivers, family members as well, to see them suffering. It can increase cost. We're worried about readmissions and more interface with the medical system. And in many of our patients with advanced disease, they may have a shorter prognosis, and we want to have them feeling as well as possible for as long as possible. And pain management is a huge part of that. We have a host of medications. I won't dive into all of them, but we always have our non-opioid analgesics to rely upon. And I think it's important to remember that even when we're moving on to more opioid-directed therapy, non-opioid analgesics certainly have a role, especially in terms of anti-inflammation, neuropathic management, and the like. And steroids, I'm going to get to them, but jack of all trades for our GI malignancy patients. So corticosteroids I find extremely helpful in an opioid-sparing adjunct for bone pain. Obviously, we're going to use it for cord compression, cerebral edema, and all the rest of it. For GI malignancy in particular, patients that are experiencing a lot of discomfort, pain related to distension due to liver metastases, even when they're on high doses of opioids, even when so many things aren't working, you can get an added benefit from steroids if it's able to be added to your treatment regimen. Of course, there's issues with hyperglycemia and bleeding risk and all the rest of it. But for appropriate patients with significant symptoms, this can be a true lifesaver. And of course, we use it often in the setting of bowel obstruction as well, not just for pain, but for decreasing associated secretions and also for antiemetic purposes. Our interventional colleagues and surgical colleagues certainly have very important roles to play from a symptomatic perspective. I know we use them often for palliative radiation, obviously orthopedic interventions, and two things I want to make sure we take home here. Neural blockade, I think it's highly underutilized and utilized often too late in treatment, in management of cancer-associated pain. So I've seen extreme turnarounds in patients that are appropriately managed with celiac blocks, splanchnic blocks, hypogastric blocks. I know Jeremy and I shared a patient who went from extremely high doses of fentanyl, multiple admissions, to getting out there to ski for his last season following a block. So there are amazing things that we can do for our patients. We just need to think of them early and often. It doesn't have to be after their third hospital admission on, hundreds of morphine equivalents a day. So don't hesitate to reach out to your interventional colleagues if you think a patient's pain is amenable to an interventional approach. Opioid analgesics, we have our pick. When I was a trainee, I would oftentimes start with oxycodone. That was just sort of a practice pattern where I trained, and I know many of us have our preferences. At this point in my career, for many reasons, I always start with morphine if I'm able, based on renal function, because it is cheaper, it's more accessible, the doses you want are there, you don't have as many issues and barriers with insurance. And it's not so much for me as a prescriber, it's in terms of access and availability for our patients and their families in the community. So I always start with morphine if that's possible, just because my patients are much more likely to be able to access it and not have issues with cost or financial toxicity necessarily. I'll switch over to Dilaudid or hydromorphone if the GFR is less than 45. So something to keep an eye on. But overall, morphine is kind of my go-to. I put a big red X across tramadol. I'm on the NCCN guidelines for cancer-associated pain, and pretty much my goal there is to get tramadol off for many reasons. But it has a lot of, it's not a great pain medication, number one. It's a partial agonist. It also causes QTC prolongation, increases your seizure threshold. There's highly variable metabolism, so different individuals are going to process it quite differently. It's just not a clean or easy drug to take, and it's not a great pain medication either. It can lead to increased delirium in the elderly as well. So I could go on, but unless there's a very convincing reason that you need to be on it, namely patients just prefer it, they've been on it for other reasons, and that's their preferred agent, but I really try to avoid it wherever possible. I have a few mini pearls I'll go through with opioids, and I recognize time is limited here, but I see these issues over and over again in my inpatient practice with dosing schedules for opioids. So our medications, and give me 1 second, let's see if I can go full screen here. Oops, sorry, bear with me. So for opioid dosing schedules, let's see here. There we go, we're all good. Over and over again in my inpatient practice, I see, and I'm not surprised why, because when you put in an epic order for oxycodone, it's going to automatically go to Q6 hours, typically Q4, Q6 hours. And the reality is most patients are going to metabolize that within about 3 hours or so, which leaves anywhere from 1/4 to 50% of their time without any good opioid coverage. So if you take one thing home today, the short-acting opioids, whether it's morphine oral, Dilaudid oral, oxycodone oral, please dose every 3 hours as needed so that your patients aren't falling out at the end of their dose without any coverage for their pain management. So thank you for that. When do I add a long acting? I have seen patients that are taking, medications around the clock, and there hasn't been a long acting added for whatever reason. And typically when my patients are requiring 4 to 5 breakthrough doses per day, so that's, that's not a lot, but if they're taking 4 or 5 doses breakthrough per day, that would be a point at which I would start thinking about adding long acting. And when you're doing that, add all of your short acting together, divide it by 2, and that's going to be your BID long acting dose. I've seen it again and again and again. People are worried to kind of convert everything into the long acting. It's okay to do it. That's exactly the point. We don't want our patients to have to feel that breakthrough pain, right? It's not insulin. We don't need to leave 20% for breakthrough. Put it all into the long acting and your patients will thank you for it. And then keep their breakthrough dose as whatever has been working, but usually it's going to be about 10 to 20% of their long acting. So if they're on 30 of oxycodone twice daily, that's 60 total, and their breakthrough is going to be 5 to 10 milligrams on average. So just think about, when to add a long acting. If you have any questions, palliative is on call 24 hours a day. I'm on call right now, so don't hesitate to reach out anytime. We're here to help. Another issue that I see often is when to increase a short-acting opioid. And my take home here is always think about a percentage increase. Now that's easy to say if we're going from oxycodone 5 to oxycodone 10, right? Their pain is poorly controlled at 5, we're going to give 10 a try. Now, if we have that same patient who's on oxycodone 20, are you going to go to 60 as easily? And usually the answer is no. There's some sort of cognitive dissonance there. We get nervous with the higher numbers, but I want you to think about the percent increase. If the pain is poorly controlled, it's safe to go up by 50 to 100% in your breakthrough dose. If they're having some control, but it's not great, I go up by 25 or 50%. All right. One thing I like to talk about here for our patients with GI malignancies in particular, fentanyl is just a fantastic drug for the right patient. If they're experiencing a lot of nausea, a lot of bowel obstruction, a lot of GI symptoms. Now it's transdermal. It's safe in the setting of renal dysfunction. It's really appropriate for patients that are opioid tolerant, that have well-controlled, stable controlled pain. It's not something you can titrate easily. I always tell my patients it's not a doodle that we can easily undo, but if you know where you're aiming and the pain is stable, it's a great option. Your patients are going to come in with bowel obstructions. They're going to come in with nausea, but they're not going to come in a pain crisis on top of all of that. So think about fentanyl. If you have questions or you're not super familiar with it, there's always a pharmacist on hand. There's always a palliative doc on hand if you need help with conversions. I'm probably going to skip through a bit of this, but one thing to think about here, fentanyl is not typically MRI compatible because of metal in the patch itself, in the matrix. So I've seen it again and again, not too frequently, thank goodness, but sometimes they come off for the MRIs and they don't get put back on. They also can't be cut or tampered in any way. So just certain things to think about when you are using these agents, but they can be very helpful for patients. They're safe to use even in the setting of cachexia. Rapid weight loss, I get a bit more nervous about, but patients that are pretty thin, it's fat absorbed and fat distributed, but it's still a great option. You may just have to titrate the dosing in really cachectic patients. All right, so I'm going to go rapid fire through a few studies I just want to share with you guys that I was excited about. The first one's going to be about cancer cachexia and olanzapine. If I should have any disclosures, this should be on olanzapine because I love this drug. I think the evidence is great for helping patients that we deal with every day. So this study came out of in India for a national program in India. They looked at patients with newly diagnosed advanced hepatobiliary gastric cancers who were starting chemotherapy, and they gave low-dose daily olanzapine versus placebo. And what they found is that the olanzapine improved appetite and weight gain compared to placebo. So there was a higher likelihood of a 5% weight gain. We're looking at 60% versus 9%, and that was statistically significant. Can you see why I'm excited? And then improved appetite, 43 versus 13%. And these are patients, you know, where appetite is going to be helpful for quality of life. Weight gain is going to be important in terms of performance status, ability to tolerate therapy. And unsurprisingly, these patients also had less grade 3 toxicities as well. So olanzapine, weight gain, appetite, it's also an antiemetic. It has some sedating properties. Give it at night, helps patients sleep, put it in the water. I'm a big fan. And because of this, ASCO did have a rapid recommendation guideline update suggesting its use for patients with advanced cancer for low dose for these particular reasons. There is no FDA approved medication for cancer cachexia, but olanzapine has its benefits. If you aren't able to tolerate it, think about short-term progesterone analogs or steroids, the jack of all trades here. What's not included is mirtazapine. So I see mirtazapine left, right, and center. I haven't seen it be super efficacious in terms of appetite, and the data is not really there either. So if you're going to reach for something, I think olanzapine can hit a couple birds with one stone in terms of appetite, weight gain, antiemetic, and also sedation. And it's cheap. Start with 2.5. I'm going to skip this one in the interest of time. There was well, now I kind of have to go into it, but basically this study looked at prophylactic radiation versus standard of care for patients with high-risk asymptomatic bone mets. I was really excited about this one. The data is really looking at breast, prostate, and lung cancer. It's not for GI yet, but I did want to share it because I was very excited. So they looked at patients with high-risk bone metastases based on imaging that were asymptomatic, so not having any pain, not needing any opioids, and they offered prophylactic radiation to these lesions versus standard of care. And there was a significant reduction in skeletal-related events versus standard of care, 1.6 versus 29%, fewer patients hospitalized, and less opioid use for these folks. So I hope this is a pretty impressive signal here with a lot of helpful downstream effects for patients. I hope we can see this replicated in the GI patient population. Understandably, it starts in prostate, lung, and breast for obvious reasons with bone mets, but I think GI would be a great place. Think about it if you have high-risk patients. The last one I wanted to cover is diclofenac for prevention of capecitabine-associated hand-foot syndrome. I don't have all of my notes for this one, but I know that this has been integrated into many of our medical oncologists' clinical practice. This study looked at topical diclofenac for prevention of capecitabine-associated hand-foot syndrome. It was a randomized controlled trial, this versus placebo, and there was a significant reduction in grade 2 and 3 hand-foot syndrome in the treatment group versus placebo, 3.8 versus 15%. There was an association with low-grade hand-foot syndrome, as well as fewer dose reductions, but that was not statistically significant. So something to think about to help prevent kind of the more severe, higher-grade hand-foot syndrome that you'll see in this treatment group. And finally, I'm going to do this in a minute, but we're going to talk about marijuana here. And the reason I want to bring this up is it's highly prevalent in use in our patient population, and I think few of our patients actually talk to their clinicians about it. So I want to bring up this research and make sure that this is on your radar. So over 75% of Americans at this time live in a state where either medical or recreational marijuana is legal. Patients use it for a variety of reasons, many of which you're familiar with, I'm sure: insomnia, depression, anxiety, so on and so forth. Understandably, there's a gap between claims and evidence. There's been an embargo on marijuana-associated research for some time, given that it continues to be federally illegal. There was a great study that came out of Sloan Kettering late last year, just looking at the use patterns among patients with recently treated cancer. They spoke to over 1,200 patients who were recently treated, and over a third reported cannabis use. And there was an increased likelihood of use among patients with GI malignancies versus lung cancer and others. With an odds ratio of 2.6. So I think our patients in GI cancers are going to be using this more than most anybody. And it's unsurprising given all the issues with nausea, pain, appetite, mood. And the patients use it most often for anxiety, depression, sleep, and pain. Use was associated with young age, use prior to diagnosis, and lower socioeconomic like income and education. And interestingly, the majority of patients, up to 90%, did report symptom improvement. So they are getting a real benefit from this, at least they're reporting this. However, only a quarter of patients that did report using cannabis discussed cannabis use with their medical oncology team. So your patients are using it. They may not be telling you about it. They may not be talking to you about it. There's 3 dispensaries within 10 minutes of here. As far as I know, they don't deliver yet, but they may as well be soon. Your patients are using it. It's out there. It's easy to access, whether it's recreational or medical, and they're getting a benefit from it. At least they're reporting it. So the perceived benefits per this study, very high percentage respondents are reporting improvement with stress, anxiety, and depression, pain management, sleep. And the 4th most common was managing treatment-related side effects. So this is because of the meds we're giving them, the chemotherapy we're giving, the opioid issues, they're having nausea, so on and so forth. They're using this to help augment their cancer care. A minority are using it for anything else. This isn't a recreational drug. Largely in this patient population, they're using it to help cope with their cancer. So I hope I covered in 15 minutes here my full agenda. That was a mouthful, but I was excited about a lot of these things to share with you, and I appreciate you taking the time. And I look forward to questions at the end. So.
All right. Well, thank you for that whirlwind tour of all the updates. So a lot of good stuff there. Nice pearls, nice pearls. So again, if there's any questions that folks have, please put them in the chat. We'll move to our final talk of the evening, Dr. Mongiu, discussing management of low anterior resection syndrome.
All right, thank you. Let me share. And there we go, my full screen now. All right. So hi, I'm Ann Mongiu. I'm one of the colorectal surgeons here at Yale, and I'm going to talk a little bit about low anterior resection syndrome update. So now that it's broke, how do we fix it? I try to fix a robot. It's made by a company other than Intuitive, and I try to make it usable here in the US. That's my only disclosure. One of the great things about the last 30 years is we've had a lot of advancements in the treatment of rectal cancer that I'm not going to go into the details of. We have better radiation, we have better surgical instruments, we have better staplers to put the valve back together with, and we've got better technology in the operating room. As a direct result of that, we've been able to preserve a patient's sphincter more and more frequently as we go back from the late 80s to, well, this is to 2006, and now sphincter preservation rates are well in the 80% if you look at it nationally. What's really interesting if you drill down is the rate of preservation of tumors, low tumors. And so these are tumors that are less than 2 centimeters and 2 to 4 centimeters from the top of the sphincter complex. So this group of patients, wow, here we are. We have saved a lot of patients who previously were only offered an APR. So is there a downside? Like what downside could there be? Well, it's something that we fondly call low anterior resection syndrome, or LARS. Somewhere between platinum chemotherapy, radiation, and us carving out the rectum and then replacing it with some portion of the sigmoid colon, we do some pretty severe damage to what is our normal defecatory pathway in our body, that mechanism by which we're able to feel that we're full, need to go to the bathroom, and are able to either hold and or walk over to a bathroom at a time of our choosing and use the bathroom, we take for granted. Low anterior resection syndrome is technically defined, at least by our society, as having at least one of the symptoms on the left combined with one of the consequences of those symptoms. And the symptoms are not great. It can be just variable function, stool consistency that can't be controlled, can be liquid or exceedingly hard. The frequency can go up, The stools can be painful and people become dependent upon a bathroom. They can't empty completely. They have to run. Not only do they have to run, but they leak. And then they may be soiling themselves at night or when they're out in public. As you can imagine, the mental health consequences of this to patient quality of life are truly enormous. How common is it? So it's about 41%. If you look at many, many studies, and this is well over the 1 year mark. So 4 out of 10 patients who we fixed their rectal cancer are having major quality of life issues. And that's really awful. It's worse than just what it does to quality of life. Beyond that is an additional stressor. We talked about other stressors for patients with cancer. It's a huge financial stressor because oftentimes patients have to delay their return to work. They have to change their work schedule. Um, their role has to change. Sometimes they can't go back because they need a bathroom. And this is a huge problem. And it causes patients who have major LARS. And so LARS is actually scored on a very easy 5-question scale. And there's no LARS, minor LARS, and major LARS. And for patients with major LARS, which is about probably a third to half of all patients who have some form of low anterior resection, the financial strain is actually enormous. We know that these patients have on average 3 to 5 prescriptions of different kinds to help with their bowels, and they have many extra visits to doctors over the course of any given year. From a global healthcare standpoint, the cost is actually about 3 times that for patients who have low anterior resection syndrome in the first year after surgery. So how do we prepare our patients for this? I think we have to, as providers, set expectations properly and look at patients' preoperative function. Where were they at before they were diagnosed? Did they ever have difficulty controlling their bowels? Where do they live? Who's at home to help them? What's their mobility status? Are they able to get up and go to a bathroom if they need to? Understanding it may be much more urgent afterwards. And being honest and saying that even if they have a lower cancer that could have sphincter sparing surgery, perhaps they would be better off without it from quality of life standpoint. Interesting that when they pulled patients before surgery. So, well, 87% of patients said that they were aware of survival data. Only 53% knew about functional alterations or the risk of bowel alterations after their surgery. One thing that we can do to help counsel patients, they've created a number of sort of visual aids sometimes for people to have an idea. And so this looks at a lower rectal cancer here on the bottom or a mid to upper rectal cancer and showing the amount of quality of life in LARS based on the location of the tumor with and without radiotherapy. And you can just see that across the board, patients who are getting the radiation, which we know can be a really large factor because it not only damages the nerve somewhat, but it fixes a lot of the tissue around where the rectum is and can make it less distensible or pliable. And we need some of that distensibility of the tissue to have appropriate sensation to do the timing of our bowel movements. And so again, here we see radiation being a key driver that's going for the patients with lower tumors who are receiving radiation, of which one of the big reasons we like to give radiation for lower tumors is it can help spare the sphincter and allow us to do these surgeries. But the payoff here is a much higher rate quality of life impairment. So how do we treat LARS? Getting into it, I always tell my patients that controlling a waterfall is much harder than controlling toothpaste. And oftentimes I find that a lot of patients have had a lot of bowel derangement, maybe from the combination of all the chemo and surgeries and many bowel preps. And when they first start using their pelvic floor again, especially since many have temporary stomas, once they're reversed, they're having loose stools. We have to fix that. And so the first place I start is doing a diet worksheet with patients. For most patients, I find that starting by cutting down on coffee, despite the fact of its cancer-saving benefits, recurrence benefits, maybe in the short term, cutting back on it a little bit can be really helpful. Avoiding the fake sugars because we know they make stool more liquid. Trying to avoid dairy because that's a big culprit, and adding more natural fiber into the diet. Beyond the basic things, we work with some prescriptions and over-the-counter aids. So to bulk the stool, we're going to recommend Metamucil or Imodium, which can be used sort of long term. For patients who, in addition to their Lars, may have had their gallbladder removed at some point, I always try to remind practitioners to use cholestyramine or cholestyramine to bind those bile acids, because after a low anterior resection, patients are really much less tolerant often of that loss with those extra bile acids and that slightly more liquid consistency. And a big thing is having all these bowel movements often means that patients spend a lot of time on the toilet and a lot of time wiping, and that can cause a lot of irritation to the perianal region. And for those who have diarrhea and incontinence who are wearing aids, they can get skin breakdown. So Desitin or any high zinc oxide based topical cream is something that's really helpful. Physical activity, we've talked about this, and in particular, physical activity, even just walking, has immense benefits on bowel quality of life. And so constipation, obstruction, bloating, predictability and regularity, gas, diarrhea, urgency, and general well-being are all improved by just walking 30 minutes a day or 3 10-minute sessions. For patients who really struggle, we can refer them to pelvic floor physical therapy. What we see when we refer people to pelvic floor physical therapy in the post-operative setting is that they will get some immediate benefit when compared to their colleagues who don't get any, but that by the time we get to a year after surgery, things have kind of equilibrated. So it speeds people to their new baseline, which can save some quality of life, but there are still patients who will linger with Lars that is not treatable by pelvic floor physical therapy. But I think we wait too long as a group in general to refer for pelvic floor physical therapy, understanding that for those who will be responders, we could get them to whatever their new baseline will be much, much faster if we just initiated it earlier. Another thing that is somewhat underutilized is transanal irrigation. And what you see here is the Prsic system. One idea is, and we use this for adults who have actually had like neurogenic colons and other congenital issues, is that the idea is if you flush out your colon, if you're able to form the stool and then you flush out your colon once a day, you can actually be able to have no leakage or accents because you've emptied it all out, once. And if the consistency is appropriate, most people can have pretty much a full functional day. It does take a little bit of training to use the system. And in our GI motility group here at Yale, Jill Deutsch is phenomenal. She's one of our gastroenterologists who specializes in motility. And she has the ability to train patients and get them set up with the Prsic system. And it can really help improve quality of life. This is the 3 months data here, and it's decreased the maximum number of bowel movements per day. It actually helped people sleep through the night. Wexner score is another score that measures incontinence and bowel discomfort, was significantly impacted, as was Lars score. So it can be very helpful. When you get to 12 months and 24 months, some of the efficacy data goes down, but not necessarily because the actual efficacy of the device goes down, but because patients don't use it as much. One of the downsides is it does take a little bit of setup and it takes some time. And so like to physically time to do the irrigation and then to empty out somewhere between 45 minutes to an hour. And so because of that, that can lead to some non-compliance as time goes on, even though it helps patients to feel better. Another option a little bit further down the line is something that we call sacral nerve stimulation. This is where we place a very tiny device underneath the skin of the low back, and we actually thread an electrode through S3 on the sacrum, and we lay it along the pudendal nerve. The pudendal nerve supplies stimulation to the sphincters, to the rectum, also to the bladder, and it helps allow patients to have better control when the weakness or leakage is coming from an inability on the sphincter part to control it. We do know that this helps. These are 2 papers that looked at sacral nerve stimulation in patients with sort of refractory Lars that was most categorized by having a lot of incontinence. It across the board, fixed a number of symptoms, including clustering, which meant people who would go sit down, have a small bowel movement, then get up, go away, have to come back 5 minutes later and do this 10 times over the course of a day. And urgency, huge benefits there, subtle benefits in control, but huge benefits in some of the areas that really cause a lot of distress. And alternate styling techniques in coloproctology showed that post SNS, no Lars, like having no symptoms at all, was really improved at I believe this was the 6-month mark in this study. So this is a technique that can be when you've sort of failed everything else. It is a surgery, it's a small surgery, but it's still a surgical procedure. And it doesn't have the best success, but it does for those patients for whom it works incredibly well. So to sort of sum it up, my treatment algorithm for low anterior resection syndrome is to set preoperative expectations pretty clearly and to measure over time. And I'm going to talk about that in just 1 second. I'd recommend that everyone gets exercise about 30 minutes a day, 3 times to 5 times a week if possible. I increase patients' fiber. I am very generous on my use of anti-motility agents. When that fails, I move to pelvic floor physical therapy or selective enemas or transanal irrigation. And then last, if all of these fail, I have a real serious discussion about either considering sacral neurostimulation or considering returning to an ostomy, because sometimes when you're chained to a toilet, returning to an ostomy can lend more dignity and quality of life. This is some data that our group had published that as we interviewed all of the academic colorectal surgeons of fellowship training programs across the country. And while 95% of surgeons do counsel their patients adequately before surgery about Lars, only 31% screen their patients afterwards. And in a retrospective study that we're just wrapping up here at Yale, we're actually showing that major Lars is still present even 7 years after surgery in a very large percentage of our low rectal cancer patients. So I think we need to be asking more. Oftentimes patients may have shame when they've been cured of their cancer. They don't really want to complain about some of their symptoms, but when we've called them back and surveyed them, it's really been a major impact on their quality of life. I have a few seconds left. I just want to talk about one thing that's worth considering. Much of our current management is reactive, so we're treating patients after surgery, and prehabilitation as a treatment modality in general is proactive. So that's going to rehab before surgery, even while patients are getting chemotherapy and radiation. It is safe. There are a lot of clinical trials that have studied this. It has been shown that prehabilitation for patients with colon and rectal cancer improves walking time, PFTs, sleep quality, and muscle mass. And there were no complications noted in any of the studies that were shown. Scott Capozza, for those at Yale, is a prehabilitation specialist at Smilo, and he's absolutely phenomenal. So thank you very much. And as with everyone else, be happy to answer some questions.
All right, thank you. So that takes us to the end of our presentations. It was worth the extra time because it was really very informative. So thank you to my counterparts for participating. If there are any questions, you can put them into the chat. I don't see any at the moment, so maybe while folks are thinking, I will throw one question out to Dr. Prsic, which is the benefits of marijuana for our patients is pretty clear. But I think that there's a lot of stigma in terms of the physicians and their oncologists actually certifying them through the medical marijuana registration program in Connecticut. So what can you say that will ease the provider's discomfort in helping our patients access it?
So we're talking about medical marijuana certification. So what I tell people, first of all, signing up to certify a patient or patients in general for medical marijuana in the state of Connecticut is about as easy as signing up for a listserv email. it's really not complicated. There's not like an hour-long educational thing. There's not this complex paperwork. You kind of put in your NPI number, your email, you know, read a form. It's very straightforward. And for those of you who have concerns about kind of the legality of it from a federal perspective, what the state is asking you to do is really to certify that patients meet the medical criteria that the state outlines to access it. So we are by no means prescribing marijuana. We are not condoning marijuana use. We are not saying that we are medical experts in the use of medical marijuana for, you know, we're just saying that patients have cancer and symptoms that are not, that are refractory to usual medical management. Sign my name, that's it. I put in their address, I put in their email. Oftentimes I'll say that they need kind of a support person so that their wife or child or husband or whomever can come and access those medications. And that is the extent of it. And the reason that I do it and that I like to do it for our patients is that, first of all, I think there is some sort of stigma about accessing these drugs. And if patients want it, it's kind of more often like I've tried a lot of things, it's not working, I want to try another option, or I want to have this option available to me at some point in the future. And I don't want them to have to go to some medical marijuana clinic or a dispensary where they're going to charge them upwards of $200-300 to have this certification done. When we know them, we're giving them cancer-directed therapy, we're doing their surgeries, we're following them for symptoms. We're as enabled as anybody else to say that they meet these state criteria, and we save them the money, we save them the time, we save them another visit. So financial toxicity, time toxicity, and the process in itself, once they do get that submitted on our end through the state, it's $100 for them and up to 4 to 6 weeks for the paperwork to go through the state. So it's not a quick turnaround for them. So it just kind of get the ball rolling so that they can access it from a medical perspective. Of course, they can access recreational anywhere as well, but the medical piece allows them to get kind of a more expanded array of options. Again, I have not visited a medical dispensary. I don't know all the details, but basically, you know, more options, and also they don't have to pay a state tax. So there's like a 30% reduction in the associated costs for these agents. I hope that allays some of your fears, but it's basically just certifying that they meet the state criteria to access it, not condoning its use per se.
All right, are there, I still don't see any questions. I'll open the floor if any of our panelists have questions for each other.
Dr. Mongiu. So this was a joke that I put in the chat, but it's a real question. I thought it was remarkable to think of toothpaste as the consistency of poop. And I think something that I try to talk to my patients about is their bowel movements. But there's such personal baseline differences and what people think is normal and what people think is normal afterwards. So I wonder how do you account for that? The example I'd have today is that I was trying to assess somebody for whether they needed Creon, and he said his stools had not changed since surgery, and he described them as clay colored but not floating and formed. And that's the kind of discussion where I think, why are they clay colored? You know, I mean, just that's a silly example, but I guess like in your world, how do patients know what their new normal is? How do we compare it to their baseline? What poops should people be having?
Well, that's a beautiful question. There's a wonderful tool. It's called the Bristol Stool Chart. It has a picture of the 7 types of poop that there are, like what they look like, and very descriptive. I actually used to have it on the wall of my clinic in New York. I need to get the stickies here, but it's very helpful. We put it in Epic, actually. There's a pathway for it under incontinence. And that's where I start with patients when I first see them, when they're diagnosed with rectal cancer, when I'm meeting them before they start any of their treatment. I usually will do a baseline Wexner in the office score, and I will say, what do your stools look like when you have them? It's a very visual aid, and you can just show it to them and get a good idea. And basically at both ends of the range, so you've got puddle and pebble, and in the middle is like a normal log that is formed. And so I say, like, the goal would be to have something once a day to once every 2.5 days that's normal, that is formed that passes with ease, but it's, not so flat that it collapses into a puddle and not so hard that it would bounce off the floor. And so that's sort of what we try to aim for, and we try to modify consistency based on, you can tell that some stools will be on the lower fiber end, and so we try to bulk up more and we try to sort of work through it from there. But color I don't get much into. I'm hoping that it's always brown unless like they have some other medical issues going on, the bile alterations that could cause the color to be changed.
And do you expect them to, if they say I always had mushy poop, what do you expect after their surgery? What's your goal?
Worse function, because patients who have loose stools or IBS-like symptoms most of their life with alternating diarrhea do much worse. And so I try to actually talk to them about that as they're going through treatment, because especially if they have low tumor, bad eating habits, and IBS, they struggle more.
Thank
So.
you.
All right. Well, I still don't see any questions, so I guess we'll finish up 8 minutes early. I wanted to thank all of our attendees this evening who joined us at this late hour. I hope you learned a couple of things. Certainly, all of us are available if questions or information or contacts of any of that is required after this event. We're here to support you and our patients. And so I wish everybody a nice, quiet evening and enjoy the upcoming weekend. Take care.
Thanks, Jeremy.